And she's working.
Good afternoon, everyone. Am I being heard? Yes, no, smiles.
Hello.
Yes, you guys can hear me great.
Hello.
I wasn't sure. I wasn't hearing anything. Hope everybody is having a great day. I'm Katara Williams, Chief of Staff here at Southern. And we're going to begin today's meeting of the Louisiana COVID-19 Health Equity Task Force. We'll begin with our normal roll call. Ms. Gerald, would you please do the honors?
Good afternoon.
Good afternoon.
All right. Dr. Sandra Brown.
Here.
Dr. Thomas Levis.
Present.
Senator Regina Barrow.
Here.
Dr. Earl Benjamin Robinson. Dr. Takesha Davis.
Present.
Dr. Rebecca G.
It still can be good.
Dr. Corey Hebert. Reverend Theron Jackson.
Here, Corey Hebert's here.
I have you, Dr. Hebert.
Okay.
Reverend Theron Jackson. Mr. Raymond Jetson. Dr. Peter Kaczmarski.
I'm here.
Dr. Kathleen Kennedy.
Here.
Mr. Michael McClanahan.
Here.
Dr. Orlando McMeans.
Present.
Representative Dustin Miller. Miss Judy Morse. Dr. Demetrius Porsche.
Here.
Dr. Ronnie Whitfield.
Present.
Dr. Gary Wilkes.
I'm here.
Miss Terry Sterling. Mr. Don Pearson. Dr. Ray Belton. Dr. Kim Hunter Reed. Secretary Kimberly Lewis Robinson. Dr. Katara Williams.
I'm here.
Dr. Adrian Wilson. Dr. Victor Jones. Ms. Delesso Alford.
Here. Present.
Dr. Damon Ijagiri. Dr. Eric Van Holm.
I'm here.
Ms. Alma Stewart.
Here.
Mr. Christopher Tyson. Dr. Alicia Bates.
Here.
Dr. Mary Meg Brown.
Here.
Dr. Leanne Fowler.
Here.
Dr. Tavell Kendall.
I'm here.
Miss Cindy Snyder. Miss Carol Smith. Miss Kathleen Tate.
Here.
Dr. Janine Thomas. Dr. Christy Anderson.
Here.
Dr. Renato Banks. Dr. Keith Ferdinand.
Here.
Dr. Ebony Price Haywood.
Here.
Dr. Robert Maupin.
Here.
Dr. Connie Arnold. Dr. Terry Davis. Dr. Margarita Echeverry.
Here.
Dr. Peter Foss.
Here.
Dr. Faye Grimsley.
Here.
Dr. Amy Lesson.
I'm here.
Dr. Rhoda Reddix.
Here.
Dr. Daniel Sarpong.
Present.
Dr. Lisa Van Hoos.
Here.
Miss Shalina Davis.
Good. How are you? Here.
Dr. Amanda Dumas.
Here.
Miss Christian Engel.
Dropping off. Kimberly Robinson.
Miss Tina Granger. Miss Catherine Haywood.
Here.
Mr. Rudy Macklin. Ms. Tiffany Netter, Ms. Erica Rogers, Dr. Derek Rovaris,
Here.
Mr. Frederick Thomas,
Present.
Dr. Jacqueline Harris,
Here.
Dr. Simone Rambati, Mr. Will Bowes, Ms. Janine Tate,
Here.
Councilwoman Cindy Nguyen, Councilwoman Helena Marino, Secretary Kimberly Robinson.
Present.
Okay, is there anyone's name called that is on now that didn't let me know they were here?
Aaron Jackson.
This is Dr. Earl Benjamin Robinson.
Terry Davis.
Okay, I have you guys. Anyone else? Dr. Williams.
All right, thank you so much, Ms. Gerald. And again, thank you all so much for taking the time out today for our meeting. It's going to be a really great meeting because we have 3 very good presentations to be delivered today relative to our health equity dashboard, communications and messaging, and racial disparities in healthcare. Before we begin, we just want to remind everyone to please mute your phones so that the distractions are limited. Also, if you have any public comments that are germane to any agenda items for today, we have a staffer standing by to receive your comments, and they'll be addressed at the end of the meeting. So you can email us at public_comments@sus.edu, or you may give us a call at 225-771-4364. Or you can log on to our website at sus.edu and click on the Louisiana Health Equity Task Force. And there's a dedicated link on that page where you can submit your comments there. So today, of course, we will have greetings with our co-chairs, from our co-chairs rather, and then we will move right into our subcommittees. Dr. Levies and Dr. Brown.
Good afternoon, everyone, and thank you for joining us today. We have 3 exciting reports that are going to be given by the subcommittees this afternoon, and we're just delighted. We're going to jump right into it. Dr. Levies, do you have any welcoming words?
No, I would just say, as of this week, we will have had a report from every subcommittee. I just want to thank all of you for your diligence and the seriousness with which you've approached this. The reports are impressive, and I think this is important work, and I just want to thank all of you for taking seriously the important work of this task force.
Thank you. And I might add that each of the reports was completed on time. We had a 30-day deliverable and a 60-day deliverable. And so the last 3 reports are the 60-day deliverable reports. We'll begin with the Health Equity Dashboard Subcommittee.
All right, thank you. I'll go ahead and begin. My name is Demetrius Porsche, and I have the privilege of presenting on behalf of our subcommittee. Our subcommittee was co-chaired by myself and Ms. Judy Reese-Morse. We also had on our committee working with was Dr. Earl Benjamin Robinson, Dr. Peter Foss, and Dr. Kathleen Kennedy. All of us want to thank the executive committee for the opportunity to work on this. We are very excited about the dashboard that we've at least conceptually begun to develop and the ideas that we have, and we're looking forward to sharing those with you today. Next slide. So just to remind everyone of our charge was to develop a dashboard and explore health equity dashboards in other states to use as a guide, and we did. We have each member of the committee was charged to looking across the country and exploring, basically diversity, equity, or any kind of inclusivity dashboards that we could find across the country, and look at the features that we liked and did not like so that we could bring them back to the group. Next slide. So our problem, just to give you a little idea, I think we all know this. We started this journey because of the number of African Americans that were dying due to the COVID-19 infection and the percentage of the COVID cases that were within the African American community, and also looking at the general population of how many African Americans we have in the state. It was definitely disproportionate and inequitable with the number of cases that we saw. So we were worried about that, and that's why I think we're calling for this dashboard to look at multiple factors that may be impacting that. So next slide. So some of the evidence that we use, we work to identify the different data elements. So what I'm going to present to you is what I'm going to call the domains of the dashboard that we have framed the dashboard around. But just know that within each one of these domains that we're identifying, there are numerous data elements that we're calling that has to actually be placed into the dashboard to create the actual data that we will have. We expecting to use multiple sources of data from the CDC to actually Louisiana Department of Health and any other data that we can use that can drill down at least at the state level, possibly by the parish level. And if we can get some information down to the city and the zip code level, that would be great. What I want to also frame is that we did take a whole equity determinants framework, and we will move on. And when you see the recommendations, I won't repeat them here, but you'll see them in the recommendations as far as the framework for the dashboard. Next slide. So the purpose of the dashboard, we figure, and this is the purpose that we're suggesting to be the purpose. The purpose of the Health Equity Dashboard is to function as a tool to provide information regarding disparities and inequities. The Health Equity Dashboard can facilitate the analysis of determinants of health, inclusive of social determinants of health, to other health and quality life measures. The Louisiana Health Equity Dashboard will provide information about effective strategies and policies to address health inequities described by the data to inform community action. And this is the key component that we wanted to pull out. Some concerns the task force has, but we want to make you aware of, not only the concern of that we have to create this dashboard, we have to maintain the dashboard, and the dashboard has to be sustained, but we continuously dialogued about this data will do no good if it doesn't get in the hands of the community and it's actually used by the community. And when I'm talking about community, I'm talking about every individual that has any kind of activity that can impact the health and welfare of our citizens and really decrease the disparity and inequities that we see. Whether it's healthcare providers, if it's nonprofit organizations, if it's some type of community-based organization, we want this to be used by multiple agents. Next slide. So here are some of the target audience we have for the dashboard. This is not an exclusive list at all, but you can see that we were thinking very broadly. All citizens should be able to come to this dashboard, get data about the area that they live in. And we can know health is very local. We're looking at policymakers, community leaders, healthcare providers, healthcare institutions, the general healthcare industry, broadening into, let's say, the pharmaceutical community, anybody that needs to know this information, that this would be hopefully the place to go and get it. Business community, other CBOs, and any kind of other coalition, advocacy, political bodies, we would really want them to use this. Next slide. So this is really where we wanted to spend our time with you today, is really looking at the recommendations. Like I said, we have concern that not only does this dashboard have to be created, maintained, and sustained, it needs to be placed somewhere. So we took the approach to actually identify where we suggest that this would be housed so that we can make sure that this dashboard is created and lives. So we identified the Office of Community Partnerships and Health Equity to have the authority and the administrative responsibility to create, implement, maintain, evaluate, so that you can continuously improve this dashboard. This would be an initial dashboard. We would expect for it to undergo modifications as it's used with recommendations. These are the 9 determinants or domains that we identified. These basically follow the determinants of health. We want to look at personal, individual, behavioral, and lifestyle factors. We want an area to look at biological and genetic, social, and then within social, we want to drill down into social and community context, education, economic stability, neighborhood, and the built environment. We want to look at economic measures, environmental measures, political determinants of health, health behaviors and health status, health and health services. And in there, we also not only have not only the types of healthcare services, but also the number and types of healthcare workers we have, looking at the healthcare workforce, and then also just to have information about the general population structure of our state. As I said, this is the heart of the dashboard. These are the 9 determinants of health domains. For purpose of today's discussion, we only have given you the domains. Within each one of those domains, there are numerous data elements that needs to be populated to create the dashboard. Next slide. The other thing that we are suggesting is that within this office, we want that office to ensure that there's a statewide community engagement process to inform the design of the dashboard and to raise awareness about the dashboard so that we could really impact health disparity. We also want the Office of Community Partnership and Health Equity to really develop a comprehensive statewide communication plan. So once we have this dashboard, we want to communicate it, we want it advertised, we want it out there so that people know that it exists and can be utilized. We also, and this is, what the committee came up with initially, we think that we will need at least 1 FTE to create, implement, and maintain this dashboard. And we also think that we'll need at least 1 FTE that really begins to evaluate the dashboard and works on the continuous improvement and ensuring the part of the utilization of that dashboard. Next slide. We also think that the office will develop and implement a comprehensive systematic quality improvement plan to evaluate that, the dashboard's effectiveness and also the statewide impact. So we also want at some point that to make sure we felt that it was strong enough to have a recommendation to just say that the dashboard itself needs to be evaluated and continuously improved, and we want a plan created. We also believe that there needs to be some type of advisory committee that continues to oversee and provide guidance on this dashboard. So we suggested some duties that would be functions of the actual advisory committee, that they will ensure the implementation of the dashboard, develop policies and procedures for the implementation. They would also facilitate and monitoring the utilization, effectiveness, and hopefully the statewide impact, provide other recommendations to the governor and agencies about the dashboard and how it can be utilized better to improve the statewide impact. Next slide, please. And then we also suggested members, which basically consists a lot of the subcommittee. We thought we could continue on to do some of this work. So we did forward some of the recommendations as who should be present initially to help get this implemented. Next slide. We also want funding to be conducted, to be allocated so we can conduct research on the utilization and the impact of the dashboard. And we actually, as I said, we did look across the country, and we also looked at some potential vendors to do what we want. And one of the vendors that came up was My Sidewalk. And the reason why this vendor came up is because they've already started working on some dashboards with the Office of Public Health, and they have some data ready to go and some elements of the dashboard ready. And then we also looked at Policy Link, because Policy Link also, they didn't develop what was called a dashboard. They developed something called basically diversity or equity atlases. And what we really liked about this vendor, they put the community context around it. So for example, if you click on a data element, you not only get what is that data element, how the data can be used, but you also get a story and a narrative around that data element and how that data element truly impacts the individuals within those communities. Again, getting back to that community aspect and encouraging the use, but really connecting the data to the community. And I'll ask for the next slide. And so the proposed timelines, we hope within a week, we're very ambitious that we could get some contracts signed whenever this is approved. And then with 1 month, we think that My Sidewalk could really begin to work on some of the essential elements that they already have. And then within a month, we could do some focus groups just on the template and the framework of the dashboard that's created within the community to get feedback on the utilization of it. And then hopefully within 3 months, my sidewalk can deploy the initial survey from the existing data set. And then after that deployment, we can also continue to have more focus groups looking around the dashboard and how well it's being used. And then within 6 months, maybe have 50% of the data elements, and then within a year, have more of the data elements actually deployed within the dashboard. The thing about the vendors that we looked at, they really need someone within the State Office of Public Health to give them the data so that they can construct a dashboard from the data sets. They're not going to actually go and get all this data for us. They want to be able to access existing databases to build the dashboard. And I think that the next slide is open for this discussion, I think. So I'll also invite any of the task force subcommittee members if they want to provide any feedback on my colleagues. Any questions?
Thank you, Dr. Porsche. We'll entertain any questions at this time. Okay, no questions at this time. That was an excellent presentation. And this was one of the things that the governor's office certainly wanted as a product, as a deliverable, tangible product. So you've definitely outlined some key steps as it relates to how the dashboard will be conceptualized, implemented, and where it will be housed. So these are recommendations that we will certainly forward.
Oh, so wait, one second. I did actually have a question. You noted in the dashboard, you listed biological and genetic factors. What exactly do you mean by that? What types of things would be in biologic and genetic factors that would be in a dashboard looking at race and ethnicity?
So go ahead, Dr. Porsche.
Oh, go ahead. I don't have the document in front of me. Maybe you have it in front of you that actually lists the data elements of that.
That was one of my suggestions. When you look at Healthy People's 2020, and it outlines biological and genetic factors, the things that are under that are illnesses that disproportionately affect certain populations, and it also are those illnesses that are genetic conditions. I believe there is a genetic condition related to certain kinds of ovarian cancers that happen that burden certain populations more than others. Sickle cell, information about sickle cell, information about HIV, and I think there is something else. So it's those conditions that are either one, disproportionately happening to certain populations, and two, specifically those conditions that have to do with genetics, like sickle cell, certain cancers only happening to certain individuals. I think it was I can't remember. I don't want to get into that.
BRCA gene for breast cancer?
Yes. So it's talking about those things.
But by calling this biological or genetic, don't we risk giving the impression that we think that race is biological or genetic and that these conditions are unique to those groups? I mean, BRCA is not only in African Americans, and
correct.
It's not only in African Americans either. So is it really helpful to put that out there as if these are biologically or genetically distinct conditions among different race groups?
Well, actually, I will say that Dr. Kennedy in our subgroup actually pointed that out. We did have discussion around that and worrying about if that is the appropriate term to use at this point. And I think at the end of the day, we went with what was listed in the determinants of health model. But we did have discussion about that, and we definitely, in the construction of the dashboard, that is part of the community reaction we want to look at. Benjamin, did you want to comment some more?
Yeah, I think that's it. I mean, it's a discussion that the discussion was had, but we just wanted to make certain that we had those things outlined that could speak to disparities that were happening in certain populations, whether it be related to race or genetics, or whether it be related to something happening more in other populations versus in another population. And so, but yes, duly noted, and we will continue to have those conversations. And it probably, when it is finalized, it won't be worded that way or look like that, because that is indeed something that could cause people to feel a certain way and additionally further stigmatized. So thank you for that, Dr. Least.
More important is the accuracy of it. I mean, to give the impression that HIV is genetically determined, or that it's race specific, could really, I think, put out information that would mislead people and could be problematic. I just wanted to also say I was for the New Orleans Health Department. I'm on their task force as well. There's a group in New Orleans who's working on a dashboard as well. I'd like to put your subcommittee in contact with them, so that because I think there's a lot that I think you both could benefit from knowing what each other is doing. So I'll reach out offline and try to make that connection.
Okay.
Appreciate that. And I also want to say we had a similar discussion about lifestyle. We did, just concerned about what could really be interpreted by if you put a variable out there like lifestyle and what implications can be drawn. I think we're going to have to really get to some sensitive and appropriate terminology.
Any other further discussion?
Dr. Brown?
Yes, sir.
I didn't sure. Thank you to Dr. Levis. I wasn't sure how deeply we should drill down into these components, even with questions. I would wonder if someone could tell me what is a political determinant.
So I think some of the variables under that is how many people are registered to vote or are actually voting by race, to look at with the political influence that they're actually having, and then looking at that in relationship to geographical.
Okay.
There's a whole body of work on determinants of health. There's a political determinant of health. There is a social determinant of health. There's moral determinants of health. So each of those determinants of health have subcomponents. Am I correct, Dr. Forrest?
Yeah, you're correct. And I'm glad you brought out the moral determinant of health. As y'all had submitted that article for us to look at, we did look at it. And if you notice, it is in the report, but we didn't pull it out as one of the determinants. We did have it. And I think what the committee struggled with is that some of the indicators or data elements that are identified right now for moral determinants of health, we came up with, how are we going to measure that? How would you measure that? And because it's so global and policy oriented, so we did mention it in our report, but we didn't put it yet as an actual determinant or domain to be captured because we weren't sure how to operationalize that. We struggled with that.
Dr. Brown, the reason I asked the question is because when we had a list of who the end users would be for the dashboard, the very first group were Louisiana citizens, just kind of generally, who do not interpret information, whose ability perhaps to interpret that data will be a little more challenged than the folks who are putting it together. So I guess what I'm really concerned about is, as we work through definitional clarity and things like that, that we're sure that it becomes user-friendly, I guess is a term I'm trying to utilize.
Right.
So that was a real focal point of our conversation. That Policy Link, we wanted to make certain that Policy Link had a part to play in helping us to strategize how should this look to the community, and what should those strategies and action steps be, so that it's just not a dashboard where information is presented and it sits there. And so one of the things that we discussed at length about, and we wanted to, and it will be in part of the dashboard, is strategies and next steps. And so that's why Policy Link is there. So because we don't want to create a situation where it's only people like myself or individuals on this call who are participating are utilizing the dashboard. It's really people in the community who need this information to help them make informed decisions, and so that they can have those conversations with policymakers or stakeholders inside their community. So that is something that is pivotal to the creation of the dashboard, not just something where we have data but the what next? What is the action? How do we do this? And so our intention is all of the efforts that we put into making certain that the data is there. We want to put an equal amount of energy and efforts into making certain that the lay people, at the very least, the lay people
Good, how
understand
are you?
this and know what this is. I also want to add, Reverend Jackson, that a colleague of, Daniel Dons just wrote a book called the
Political Determinants of Health.
Determinants of Health, and it's a great book. And so I would just recommend you. It's a great book.
To that point on political determinants of health, in his book, he focuses on going beyond what the evolving discussion has been about social determinants of health. And what he suggests is that we should start talking about drivers of the social and health inequities. And he notes that there are three major aspects of political determinants: voting, government, and policy. So perhaps if compromise could be if we utilize the terminology political determinants of health, then it's further explained that entails voting and how one should do that. That entails policy and that entails government. So I would just add.
I just wanted to add that in our discussion, I think Dr. Benjamin made this point. It's very important. It was very important for us to have a mechanism by which the citizens could understand the purpose of whatever that determinant was. So Policy Link had a unique approach to it, where when you click on whatever the determinant was, then it would tell you how you could use that information to make changes. And that we felt that that's really the only way that we're going to eliminate some of the inequities, that people understand how to use the data and not just look at the data. So that's why we made that recommendation.
Right.
Thank you so much.
And one of the strong points of My Sidewalk and Policy Link is that they were able to take the data science and transform it, if you will, into to an audience that would be engaging, so that they were able to tell the right story. Also, that it would be accessible via mobile devices. So there were a lot of perks to that, if I do recall. Well, these are all wonderful suggestions and dialogue. Is there any other questions or comments for the Health Equity Dashboard Committee? Okay, we will move to the Communication and Messaging Committee.
I'm waiting to share the screen.
That's with Dr. Rivera's.
Yep, waiting for the screen share. Okay, are we good now?
Yes.
Okay. Good afternoon, everyone, and thank you for being present for our presentation. Having viewed several others, I was a little bit intimidated by having to make a report such as this, but I was comforted with a great team to work with. You see their names there on the screen. Dr. Keith C. Ferdinand was incredibly helpful in helping with the report. Dr. Corey Hebert has lent a great deal of support in terms of production and helping us to get messaging out. Councilwoman Moreno and Wynn have joined us as well, but our real hero right now is Ms. Janine Tate, who joined the committee fairly late, but has been instrumental in getting a lot of work done. We are also grateful, of course, to our co-chairs, both Dr. Levis and Dr. Brown have been attending our meetings, and up until very recently, Dr. Levis was leading this committee, but he has stepped down, and we'll explain that in just a bit. Our priorities and goals are quite simple, and that's to deliver health and safety content messaging to those who are most vulnerable. And we identified those as the aged, young adults, people of color, and those who are economically disadvantaged. The statement of the problem, we've heard these numbers before, but just a quick update. As of July 1 of 2020, there were 2.6 million total cases in the US and 127,300 deaths. In Louisiana, there were 58,095 cases, 3,221 deaths. 1 week later, just yesterday, the numbers indicated that there was an increase of almost 14,000 cases in Louisiana, and we had another 26 people die. The urgency of now is why we share that data, and that's the statement of the problem. These increases are staggering, and they continue, especially within our 18 to 24-year-old age group. These will hopefully not lead to the kind of spikes that we saw in the elderly, but we're starting to see very negative trends for the 18 to 24, including talking with Dr. Hebert earlier today, young patients with COVID at the Children's Hospital. Any delay in communication and messaging can increase the likelihood that more people will contract COVID-19. And of course, as Dr. Ferdinand points out, more hospitalizations result, and ultimately more people will die. So we need to get our message out quickly. We need to have them out at affordable and cost, and we need to target our younger and older members to make sure that the message is getting to them, as well as to those who might be economically disadvantaged. Bit of background information. An existing website, The Skin You're In, that's hosted by Tulane University, was agreed to be used as our website. We'll share that with you in just a moment. But that website was fairly substantial, and much like the conversation that preceded this, where there isn't a dashboard being created, we simply capitalize on something that was already out there and that could help us get our message out to a wider audience. It's important to note that this subcommittee, unlike many of the others, was not designed to do deep dive research, but we were charged with producing and making a product. And so that product is advertising and messaging throughout the state of Louisiana, especially targeted to the groups mentioned before. We spent a number of weeks. This subcommittee started a little bit later than some of the others, but we spent a number of weeks, perhaps 4 or 5 weeks, just studying the marketing mechanisms and trying to figure out how we could get our message out, who would be the best audience. And that was aided by the LSU Manship School of Communications team. There was a bit of frustration, and I'm being kind when I say a bit. As a matter of fact, there was a lot of frustration that we weren't able to get messaging out any quicker than we did. That being the case, we noted that we needed to work fast. The numbers I shared with you earlier dictate that. While we're trying to look for vaccines and cures, we absolutely have to focus on our special populations and make sure that whatever we produce, whatever information we give, including social distancing, or as we call it now, physical distancing, wearing a mask, of course, is important, that it be targeted with culturally sensitive, literacy level appropriate, and evidence-based information. Dr. Ferdinand likes to refer to literacy level appropriate, something that 8th graders can understand. If we dumb it down too much, then it is not reaching people. If we elevate it too high, we'll miss folks. But we want to make sure that it is literacy level appropriate for all. And I did mention that Dr. Levis has as recently as June 26th, passed the leadership of this subcommittee over to me, and we're getting busy right away, including messaging that I'll share in a minute. The website that we've been using, The Skin You're In, is hosted by Tulane University, and if this works right, I'll be very happy. I'll try and click over to that link, and you all tell me if you can see it. Did the website come up on your screen? Yes. No?
Dr. Rivera, would you like us to click on it? It's.
I can click on it. Let me do it from this end.
Okay.
If I just add the screen share. I was afraid I'd have to do that.
That's it?
No. Can you see it now?
Yes.
No, that's not it. I'm sorry. They again disabled my screen. I don't know what's going on.
What we're showing now is the skin you're in.
The skin you're in is showing up?
Yes, yes.
Okay.
We're doing it from our end.
Okay. Okay, can you scroll up a little bit on that? And keep coming up. Down at the very bottom, you see the COVID-19 Equity Task Force. So we are fully listed there. If you go back, if you click on that, right, that Louisiana Task Force button for me, you'll see that that is linked to the Office of the Governor and the announcement of this committee. If you click back out of that, so this website has both the governor's page as well as our unique page. And you're going to go to COVID-19 tab at the top. You can just click on the tab and you see the Health Equity Task Force. And there's our webpage, which is hosted by Southern University. So I bet Tulane doesn't know that they've got a Southern University page, but we won't talk about that. Our webpage is, and if you scroll down, you can see to the left our tab. This is looking like a real web page, folks, and you can even click on our reports and other things that we posted. So that is up and is on that website, The Skin You're In, which was part of a project that Dr. LaViste and others over at Tulane put together to look at health disparities even before this COVID situation took us. So let's go back, if you can, to my screen with the rest of the report. Somebody wake Corey up.
I'm up. Here I am.
There's my boy. Okay, so I'm trying to see.
And you're doing a great job, by the way, Derek.
Thank you, cousin. Thank you,
Yes,
cousin.
you are.
I'm working with this technology, though. So if you could please allow me to share my screen one more time so I can scroll us through this. You cannot start screen share while the other participant is sharing. I'll wait.
While we wait on that, you should know Tulane is very much aware of the Southern Language website.
All right, good.
A beautiful partnership. Beautiful partnership.
Yeah, you're right. For those who don't know, our co-chairs are representing those two fine institutions. All right, so we're gonna go back to this, and I think we were at this slide. Are we back on?
Yes.
Okay. Initial messaging will center around protecting older adults and those with high risk conditions, mask wearing, and the concept that younger adults should do it for the community, since we are one. And we got the brainstorming, and everybody on our committee, and I mean everybody, likes music. So we stole from our friend
Mays.
Frankie Beverly and Mays, and said we are one, and that's why we wear our masks, not just for ourselves, we wear it for others. And then we looked at the group Guy and their song, I can't even call the name.
Groove Me.
Groove Me, thank you, Corey. At the end of that song, they shout out, "It ain't over. The party's not over." And that's the message that we wanted to get to people. And this was something we came up with 3 weeks ago. And since that time, it's been made very, very clear that the party certainly isn't over. And the spike is continuing to demonstrate the importance of getting messaging out in a timely fashion. Again, we talked about having those, talked about having those messages available. in Spanish and Vietnamese. And at this juncture, we're talking about superimposing that information on the screen if necessary. The first commercial message has been developed, and it was developed by Dr. Eric Griggs. And some of you might know Dr. Griggs. He's known as Doc Griggs for his ability to share messages about healthy lifestyles. He and Corey Hebert are good friends, and Corey enlisted the help of Dr. Griggs to produce our first video commercial. So we'll share that with you here. Let me see if that works. And are you able to see a commercial on that screen?
Yes.
Okay, here it goes. Let's hope you can hear it as well.
First of all, I wear a mask in public, not for me, but for you.
I want you to know that I'm educated enough to realize I cannot have
Not
it
playing.
and still give you the virus.
It's not playing?
Wearing a mask doesn't make me
We could do it from our end, Dr. Rivera.
You have it? Okay, please do.
Let us do it. Tell Corey to. You're doing a great job in coordinating all these back and forth logistics.
Baby, you don't even know.
There we go.
Kennedy was looking for you.
First of all, I wear a mask in public, not for me, but for you.
I want you to know that I'm educated enough to realize I cannot have any symptoms and still give you the virus.
Wearing a mask doesn't make me weak, scared, stupid, mean.
The world doesn't revolve around me. It's not all about me or my company.
If we could all live with everybody else's consideration in mind, the world would be much better.
We wear our masks because it ain't over.
Thank you so much, Sandra. And if I could return to my share. Okay, and if one last time I can get the screen back, I think I do. Let's see.
Derek, can we make sure that the entire task force, including the subcommittee members, gets a link? Because with what we just saw, it's really, you couldn't really see and watch the video.
Okay.
and like in 4K that it was shot and hear the music and all that.
Yeah, we didn't do it justice, and I do apologize because Dr. Griggs did a fine job of putting that together with his team, and it featured the voice you just heard on that, the inimitable Dr. Corey Hebert. So we do want to get that link to everybody. And
Tracy will forward it. Tracy will forward it.
It can be forwarded. It's in a Dropbox, which probably made it a little difficult. So are we back to my screen?
Yes.
Okay. Do this here. We also plan to utilize the governor's website in order to help spread the social media information that we want to get out. Instagram, Twitter, and Facebook. Some of you are familiar with those. We're trying to get to places where people can get this information as quickly and as readily as possible. TV is quite expensive, but we're working on something that I'll share it toward the end. We also want to utilize what already exists. And so we lean on the governor's page to help us get some of that information out. We're also, and I'll have an update on this too toward the end, working on our own standalone social media platforms. given a budget of $150,000 to deliver this message in a very quick fashion, we wanted, again, Dr. Hebert was a stickler for this, that we want to produce high quality messages, as he referenced the 4K imagery. We want to make sure that it looks good and that it makes a coherent message to folks, and we want to get it out quickly because we have had this delay. So right now we will not be using network and cable television or radio spots, but we're focused on some more affordable avenues that Ms. Tate has helped us to secure, working towards securing. We'll continue to use these social media and digital platforms right now, but then we will also be placing information on the Advocates websites that they have South Louisiana covered, from Baton Rouge to New Orleans and Acadiana. And then we'll be looking at Central Louisiana and Monroe Shreveport area as well. Also, we've begun to look into digital billboards locally here in Baton Rouge and as well in other places. As you see down there, buses, streetcars. A new exciting piece, I think, is the new logo that we're working on. As we looked at the logo that was presented, and ironically, Janine's team was the group that put it together. It reflects more of, and you see it at the top of the page there, it reflects more like a letterhead than a logo. And so they're working on something as we speak. And as early as next week, we should have all of that up and running. And then recommendations. So we seek to secure additional funding that will help this task force do television, radio, and others. We are very optimistic that we have the ability to produce high quality videos and short commercials like you saw, upwards of 15 to 20 of those, that we can get messaging across the state in a fairly quick fashion through social media, but we will also use those as we up our game into television and radio. We also plan to do an analysis, going back to that same team from LSU, of the effectiveness of the reach of this communication messaging strategy. So here's some updates as of 1:30 p.m. And I told you Janine was super. She sent me an email and I converted it to a slide for this presentation. We are actually finalizing 2 new logo options. The new social media Facebook accounts will be up as soon as the logo is finalized, which again should happen next week. Right now, we'll publish what the governor has published. We'll post what the governor has published, and as well, we will add the Dr. Griggs video to his site. We have a designer at Southern who's working on 3 branded graphics with messaging about social distancing, wearing a mask, and as well testing. We have not worked at length on the testing aspect, and so this is a new part for us. We've received quotes already on bus shelters and backup bus advertising for Baton Rouge and waiting on New Orleans, recognizing that especially for the target populations that we want to hit, these are good means of advertising and getting messages out. We're also sensitive to those who don't use social media and cell phones and things like that, for smartphones anyway, to get their information. And so that's a reason we will have to go to these billboards, buses, and eventually television. Billboard quotes have been obtained from Baton Rouge, New Orleans, Lafayette, and we will look at Central and North Louisiana as well. You can see a typical budget right now for statewide television. Again, this is being negotiated, and when we move to the major networks, and certainly when we move to cable, it gets a whole lot more pricey, but we're going to work that out. And I can't say, did I say thanks, Janine? Thanks, Janine. You are the best.
Oh, thank you so much. And check your inbox. I sent you the logo options.
I did see them, but we didn't get to screen them with the committee, so I didn't want to share them until we have a look.
I was letting you know they're there.
All right. That concludes our report. I would entertain from, I know Dr. Ferdinand and Dr. Hebert, as well as Janina on this call now, if you all had any other information you want to add.
Yeah, can I be heard?
Yes, sir.
Yes.
Yeah, this is Keith Ferdinand. One of the things that Derek did in taking up on the leadership that Thomas had already initiated was to try to move as quickly as possible. My floor, where I have my office at Tulane, is the same floor where the virologists are the leading people who are investigating this virus. And I think all of us as human beings, it's difficult to accept disaster. Being from Louisiana, we watched the hurricane bounce around the Gulf, and we never believe it's going to hit us. What I'm hearing and what I believe is that the uptick we see in young adults, they're going to go visit their auntie and their uncles and their grandma and go to the store, and they're going to infect older persons who are immunocompromised and have other conditions. The hospitalizations are going to follow, and we're going to see deaths in 1 to 2, maybe 3 weeks at the most. And my personal conviction is, because of the high numbers that we're seeing, the deaths are going to rival that of April, and they may even top what we've seen in April. So we need to get the message out. We need to get the young people to cool it, and they can have fun next year. And we need to try to get these messages to the population who have been perhaps, I don't want to use the word foolish, but perhaps have been foolish in their activities and are going to potentially harm the older persons and the people with other conditions and are immunocompromised. They're the ones that are going to really be hospitalized and die in the next 1 to 2 weeks. So this is serious stuff. And that's why I appreciate Derek and Janine and the speed at which they have started to get these messages out.
Anyone else from your committee that would like to share anything, Dr. Rivera's?
I can, just as an aside, folks, trying to get a message out to Black folks. We are Black folks, and we kind of know what we need. And basically the reality of all of it is that everybody needs to be addressed. We don't really need to, at this point, start pigeonholing different groups. As Dr. Ferdinand said, this is going to affect everybody. And so on our purview, just so the rest of the task force will know, everybody is on our radar for us to be able to get to the message out. And we have other people that are on this task force that are very well known in the community. Dr. Whitfield, I know, is on the line. We'll be calling on him, and we'll also be calling on a lot of other folks that are on this task force to be in some of these ads and look for your information as well as your input on any ideas that you think would really penetrate for our community. So we're open, and we had to get something out. We know it kind of looks like an art cinema film, but we wanted to, and this is something that I think Dr. Griggs wanted to look at it as well as I, is that the first thing that came out, we wanted it to look like it came from something real, not just, the message that you have one person telling you to put on a mask. We wanted to have some type of cachet, so know that we're not playing around and that we're going to make the messages poignant and penetrating.
One of the other things that we've talked about are some of the other kind of ideas for messaging. And when we were working with the consultants, there was a question about who is our target when we put the message together. And we said everyone. And then the consultant said, well, do you mean the target population that we're talking about? And we said, no, we mean everyone, because in order for those target populations to be healthy, we need everyone to be wearing masks. We need everyone to be physically distanced. And we need everyone to continue to wash hands and get tested if possible. And so our messaging, while we will focus on those groups, we will not exclude anybody as we try to get the message as broad as possible. One bit I will tease, and we haven't worked it out yet, but Dr. Hebert came up with an idea of an older Black woman scolding a young white college-age kid for not wearing his mask. And I want to impersonate Corey's impersonation of the old lady, but I think it's that kind of messaging that we will cross lines of culture, race, and age to get this message out.
I don't want to say that it was scolding, Derek. I just.
But now you got to do the impersonation, bro, so everybody can determine for themselves.
Yeah. Yeah. Okay, scolding.
All right.
All right. Any particular specific questions for the Communications and Messaging Subcommittee.
Yeah, Dr. Brown.
Yes.
Thank you. Let me just say to all the gentlemen, the folks who had anything to do with this, it was a good job. Well done. My concern was, well, maybe I ought to preface by saying this. I'm from Southwest Louisiana. I'm from Lake Charles. I have been up in Northwest Louisiana for the last almost 30 years. And so I'm becoming sensitive to their concerns about the lack of sensitivity below I-10. We talk about the, where we're going to get the message out to. I don't want us to forget the city of Shreveport, which has several major hotspots. I'm officed in one even as we speak in the Black community. We have several communities here who have been hotspots. And when I listen in context to statewide conversations, we will talk about Baton Rouge, New Orleans, and then we'll say North Louisiana. We wouldn't anymore say, the Lake Charles, Baton Rouge area. We don't say that. And that's about as close as Monroe and Shreveport are to each other as well. So when we start talking about the Monroe, Shreveport, we don't really share television markets or anything like that. They're close to Mississippi, we're close to Texas. That's just, you understand how that goes. So often I just think that gets lost in the conversation, and the people, and I'm only saying it because I'm from South Louisiana, we really don't care much about how folks feel up here sometimes. But I just want to be sensitive to the fact that that when we start talking about markets, it's very important that if we're going to be in Central Louisiana, there are 7 times the number of people in Northwest Louisiana than there are in Central Louisiana. So I just want us to be sure that that we're doing just as it relates to the equity with which we share this message as well.
Yeah, I think it's interesting because so many people don't like Shreveport area because they cheer for the Dallas Cowboys.
I'm with you on that.
I have no say-so in that, and so I will make sure that we include the Shreveport area, independent of the Monroe area, but also independent of South Louisiana. That you're exactly right, and they're part of this state, and we need to address them appropriately.
I also agree with that. I also agree with that, and I think it's even more important because some of the hotspots are actually highest outside of the New Orleans metropolitan area, although you have a lot of people here. And the other thing, we know that the virus not only does not know state lines, it doesn't know interstate lines. So clearly, it's going to travel throughout the state. And I know that we're going to make sure that we get the messages out and we identify markets outside of New Orleans, Baton Rouge. It will be Monroe, Shreveport, in between Prairie View, Cut Point, whatever you want to do, Cane River.
Bunky.
Yeah.
This is Mansura, Marksville.
Yes.
We failed you on that, Brother Jackson. I do want to apologize if we weren't explicit, because as we look at our advertising, we are looking across the state. And we're targeting, and initially what I joke about, Bunky, we are targeting the larger medium markets first, given the limited budget. And then we want to make sure we get the message across the state. So thank you for that clarification.
One last comment for me. Derek implied that we kind of started to move fast because of the uptick. And I don't think that was really he was saying. We were trying to move fast. Thomas can back this up. We were trying to get some messages out because we thought there may be an uptick coming, even before the uptick. So it's not as though we've been energized by some news reports that we heard. We always felt that there was a possibility this virus was going to start to spread again, and it was going to hit the racial ethnic minorities heavy, and we need to do some messaging. And all has happened now is that our prescient views have been optimized by what we see in the media. What I say in big old college language is the reality has hit us in the face to make us move faster.
8th grade, bro, 8th grade.
I had a comment. Can you hear me?
Yes.
Hello? Yeah. Look, when I saw that, great job. You did an outstanding job. Is there any connection with any national messaging? What came to mind when I saw this was the scene in School Days when, they're ringing a bell and asking people to wake up, So I don't know if there's any national campaigns of messaging, but Spike Lee, combining School Days with the message of wake up, ringing the bell with do the right thing, I think would be a great message that would resonate with particularly young people because that was targeted to that college crowd back then. I mean, it worked for us when we were all, I guess, in that era. So I didn't know if you all had reached out to any national messaging type of opportunity.
I would let Corey speak to that. I don't think that we have. I think that's a great idea, but we have not done that yet.
We have not. Trying to get a couple of things in the can from the ideas that we have from the committee, as well as from the task force, is what we were looking at, just at the beginning. But now everything is game, and we are looking at other states trying to do the same thing. I mean, just like our state, use your head, stop the spread is a great one, and other states are using that right now. So we are going to. There's no reason to reinvent the wheel, but Louisiana is a very unique place, and we want to be able to do some very unique things with our different ways that we handle and the different things that we say, and so it makes it much more penetrating. But I totally agree. I think that's a great idea. The wake up message is a great idea.
Dr. Hebert, can any of these messages be translated for the Hispanic, Asian community so we can have a widespread of the message across those communities as well?
Yes, we actually, Helena Moreno is on our committee, as well as Cindy Nguyen. So we're talking about translating all of them into Spanish and Vietnamese. I mean, theoretically, Chinese in places where there are a higher Chinese population is also important. So we will, and Japanese as well. So, but the top three that we're looking at is just English, Spanish, and Vietnamese. We were looking at Ebonics, but we decided against it. but it ain't over.
It ain't over.
I just want to add, I think, and this is to Reverend Jackson's point, something that has come out of the task force as a result of the skin you're in, and also to Dr. Griggs and Corey Hebert's communicative work is at LDH now, we have started a COVID-19 communication advisory board. And so we've asked individuals, some who are on this task force and others who are from around the state to be on it. And at the present, we've asked the communications professor at Grambling State University, a social worker who works in communications in Shreveport, Tawana Harris, and a community health worker in the Monroe area to be on it. And we'll be asking others, but just wanted to share with you that, to your point of making certain that we are creating opportunity to get messages to everyone equitably, that we are, as a result of what has happened on this task force, LDH has developed that advisory board. And what we intend to do is to create communicative synergy so that we are getting the message out most efficiently. And it is getting to the people that we need to get it to. And so I will have a person from my staff reach out to you if you want to attend the first meeting. It will be happening relatively soon. But just wanted to share with you that one of the great many things that has come out of this task force is that synergy, our social capital that's needed to move this forward as it relates to communication. And so we will be developing, or we have developed, an advisory board, and we are being very, very targeted and strategic about that. It's just not South Louisiana heavy, that it has representation from around the state. And so I'll reach out. I have someone from my staff reach out to you soon.
Thank you.
Well, I just wanted to close this portion of the meeting out by thanking Derek.
Well, Dr. Levice, I'm sorry, can I interrupt? This is Kimberly Robinson, and I just on the last presentation from the Communications and Messaging Group, there are two communications plans that are targeted to the community. Dr. Hebert and Dr. Whitfield have both done commercials for those that are currently on both social media and on cable. And I think that Dr. Jackson, I think you did a radio spot in the Shreveport market, and I know some other ministers around the state have done those same things. The Get Serious Louisiana campaign on behalf of the governor. So we are doing targeted messaging, and that is a platform. So if you have content that you want to spend the money to develop, we're already running the ads. So if you want to send, we distributed the one commercial that you just showed. We did that on social media on, I guess, Friday on the Get Serious platform. So if there's content you want to develop, we already have the ad space out there that we're running for the next 2 weeks, at least through July 28th. So as opposed to the task force trying to figure out how to stretch the funding that you do have, why don't you work with us on this, with the messaging that you want to target? But we have been messaging since April, and some of you have been a part of that messaging. The CEO of the New Orleans East Hospital is in one of the commercials, I know. I'm trying to remember all of them. So there are members of this task force that have done commercials specifically that targeted messaging about all of the things you're talking about. So those campaigns have been running for the last few months. So I didn't want, for those of you that may not have seen them or are not familiar with them, they are out there. And they've run on social media and on cable and network television. And they're running right now.
And Kimberly, that was part of our report that we are working with the Get Serious website, Get Serious Louisiana website. And I believe Sandra reached out to you to get that first video placed on there. So yeah, we are not, as Corey said a couple of times, we're not trying to reinvent or do everything that needs to be done. We're simply augmenting and producing what we produce. So there is every bit of cooperation that you need.
No, and there's another platform as well in the New Orleans that's also based out of New Orleans that's going statewide as well with the Jalen group. So there are two different groups. So I just want to make sure that we're using both resources. And they definitely reached to Shreveport because I didn't want
I was
Dr. Jackson to know.
You're about to get me in trouble again. Don't say New Orleans.
I didn't want to. I didn't want Dr. Jackson to chime
Reverend
in.
Jackson come on here, and you know it's gonna be a
They are
misunderstanding.
statewide because I know better. I know how to get to I-49.
I know that's right. Yeah, I did a commercial myself, so it is.
That's
true.
right. I know how to get to I-49. I am not confused.
Thank you, Secretary Robinson. Dr. Levy?
Yes. Yeah, thank you. I just wanted to publicly thank Derek when I called him up and said, look, I'm drowning and I really need someone to take leadership of the subcommittee. Derek stepped up immediately and stepped up with great enthusiasm and very quickly picked things up where I left him off and was able to move forward. And I want to thank you and the rest of the committee for taking leadership and moving this forward.
And I echo those appreciations as well. Dr. Rivera's, you had to step in a short amount of time to get a quick turnaround. So we appreciate the efforts of the entire committee. We do, as he says, have funding. We have to stretch a dollar, but we do have some funding allocated specifically for communications and messaging. So we will provide as much of the resources as we can.
Thank you.
Thank you.
Thank you both.
Okay, we'll move forward to the last committee report, which is racial disparities in healthcare.
Thank you. I think, are we going to bring the slides up?
Yes.
So while we're bringing the slides up, our committee, our Racial Disparities in Healthcare Committee, is appreciative of the opportunity to close out the reporting. And we are very impressed by the work of our other subcommittees. And so we look forward to input and questions regarding the recommendations that we look to move forward. Next slide. I'd like to begin with acknowledging the passion and the dedication and the hard work from all of our committee members, including co-chair Dr. Gee, Drs. Anderson, Lesson, Drs. Davis, Dumas, and Ebony Price Haywood. I also would like to recognize the contributions of a number of colleagues who lent their input to some of our key core areas. through our pulmonary care division at LSU Health, Drs. Pugh, Pioma Brown, and Dr. Lemmy, and the work that was brought to bring all of our efforts together by Will Bowles, who's a senior medical student at LSU, who's working as a health policy intern with Dr. Gee over the course of this summer. Next slide. So there are a couple of areas that I think found and that are at the foundation and sort of ground the work that we've done. And our work has really been focused around structure. That's really been the lens or the perspective that we've tried to bring to how we've addressed the core priority areas that have been part of our charge. And so we recognize that when we look at the challenges in terms of healthcare disparities that confront the citizens across our state, that these really are rooted in a structural legacy in which we see areas that have been not as functional as they need to be in terms of advancing equity, whether we're looking at our healthcare workforce, our educational system that helps to develop the workforce, or if we look at really the function and design of many of the core elements of our healthcare delivery system. The challenges that we've had in that space in terms of structure have been part of a legacy of challenges that I think have come down over the decades from the era of Jim Crow. And so, the time is now for us to really look at dismantling the areas of our structure that impede our progress in terms of equity. Next slide. I think the other area that's a foundation for the work that we've done with our subcommittee is looking at is recognizing the fact that in terms of best public health practice, we need to transform change and move forward new platforms at the foundation of the public health pyramid, and that is in the space of our populations and our systems. I think in many instances, our efforts and work is really focused too often at the top of the pyramid in terms of trying to influence direct services at the point of contact. And that really only lends to marginal or incremental gains in terms of improving equity and reducing disparities. And so it's really now the time for us to look at changing this narrative across the foundation of our health systems. Next slide, please. And so, I think that our subcommittee had a fairly heavy lift, given many of the core charges that were brought to our space, and which really moves beyond simply sort of a more short-term response to the COVID pandemic, but also looking at how do we structure and look at best practice approaches in terms of policy and design that will impact our ability to move our healthcare system forward to address inequities and to address disparities on a go-forward basis, and to be prepared for the next pandemic or crisis, and just for the ongoing pandemic in terms of health disparities in the state that we've too often been on the wrong end of the curve. So the core areas that our group worked with included taking a look at the crisis of care standards, specifically through a lens of equity. Second major domain was to look at how we address best practice and evidence-based solutions that address disparities in healthcare in terms of the way we are delivering care. And then lastly, looking at opportunities to, in a structured way, decrease bias and medical mistrust, again, by looking at how do we reform and address these elements within our healthcare workforce. Next slide. So in looking at the crisis for care standards, again, our focus really is to address these through the lens of equity in terms of how they're applied. Recognizing that the crisis of care standards are designed to allow us in terms of public health and health systems response, to scale up to events such as our COVID pandemic, from conventional care through contingency care and into modes that support what is needed to respond in a crisis mode. One of the things that we learned as we interfaced with some of the health leadership entities as we looked at this specific area was that we in fact did not leverage or execute the standards that had previously been authored and put in place within the state. And in some respects, that was because there was a determination that we were more in the space of contingency than crisis. I think that, our committee felt that, that was a decision that I think on a go-forward basis, we would ask to look thoughtfully at, because, I think we really have navigated, especially as we're seeing sort of the respike in terms of the pandemic that affects our state, that we need to think critically as how we leverage the resources and tools of these standards in terms of crisis. So with regards to, again, the lens of equity, our focus is to look at policies that address disaster scale up, that are developed to address equity, justice, and cultural competency, that's rooted in the values of the communities that we're serving. And so that as we scale up and respond to crises, we don't fall into the trap of executing things in a way that further enhance or widen the disparities that already exist in our communities. Next slide. Next, please. So, let's go back. Let's go back two. I'm sorry. One more. Go back one more slide. So our first recommendation focused on looking at some of the operational infrastructure, and specifically a recommendation to develop, in the process of navigating the crisis standards, a community engagement and health equity committee that will inform the decision-making and the rollout of delivery of services in a way that ensures equity. And that is probably going to be a central function that can function at the level of the health department and/or in a regional context. Secondly, from an operational construct, we want to look at the best use of triage committees at the level of institutions that have the operational function in terms of determining how physician and healthcare worker decisions navigate the process of triaging individuals that are coming in for necessary care, and that the approaches are executed both with consistency and fairness. And so the membership of those bodies should go through navigate a process of formal training in terms of bias and cultural competency to ensure that as they go through the process of executing the protocols, that this is done in an equitable fashion. Next slide. Another key and core recommendation relates to the principle of how do you best navigate triage and allocation of resources for critically ill patients who are admitted in the setting of a crisis such as our current pandemic. So the guidelines that are involved in this space should really empower and enhance the ability of individual institutions to plan for the scale up in a way that serves and protects equity. Next slide. Our third recommendation relating to the crisis of care standards, again through a equity lens, is to look at how one of the things that occurs is there usually is an approach in terms of scoring systems that evaluate disease acuity that dictates to a great extent how resources are allocated. And that allocation of resources needs to be in a fair, just, and equitable fashion. And so we need a process to inform the triage committees in terms of their decision-making that's really informed by community stakeholders that allows us to move forward in an equitable fashion. There's been commentary recently in the New England Journal that's identified that from a national standpoint, when respective peer states look at executing the use of crisis of care standards, that the disparate allocation of resources is often a significant challenge. And so this needs to be critically evaluated in terms of the way our existing documentation is constructed and how the standards are actually leveraged when they're used. Next slide. Our last area really focuses on the space of how do we address cultural competence as we navigate the space of the use of crisis scale up to address the needs of communities from diverse sectors of our state, especially those with limited English proficiency. So that, as has been highlighted by those in our communication committee, the resources in place that are and the execution of the scale up does not leave anyone behind, and especially because of differences in language and or culture. And so we recommend that we need resources in place that as individuals move through our institutions in settings of crisis, that we are being mindful of their preferred language so that we can effectively communicate. This is both directly and in written documentation. And that we have resources in place that allow us to leverage services such as in-place in-house medical interpretation, and that we align our systems where we actually have personnel and staff who are reflective of those communities. That requires a significant investment. It's something that we clearly are challenged with even in our current models of conventional care, but these resources need to be addressed even in the times of conventional care so that they are assets when we actually are scaling up in windows or periods of crisis. And so this is a critical area. So again, that we understand and know how to best do this so that our communities that have diverse cultures and language needs are not, again, marginalized as we scale up our crisis resources. Next slide. So we'll transition to our second core area, and that is the charge to evaluate evidence-based solutions that address disparities in care as it's delivered in Louisiana. Next slide. So our focus, it was very insightful that several of our committee members brought forward the approach to focus on a key resource that is often underutilized in terms of leveraging how our systems interface and advance the well-being of our communities, and that is looking for greater alignment and accountability with the community health needs assessment processes and the use of development of community benefit programming by our health centers. As a matter of background, not-for-profit hospitals are charged to demonstrate a commitment to community service through developing organized and sustainable community benefit programming. And this is actually a charge and a requirement that is a federal mandate if not-for-profit hospitals are going to retain their tax-exempt status as codified by the IRS. And about a decade ago, with the Affordable Care Act legislation, there were additional requirements that processes for a community health needs assessment tool and or procedures needed to be recurring events over every 3 years, and that the results of the community health needs assessment evaluations should result in the implementation of strategies that meet the community needs that are identified in this framework. Importantly, this process has to take into account input from stakeholders from throughout the community who have broad interest in terms of addressing those priorities that reflect the communities in which many of our health centers are embedded. And importantly, that this area of activity has to be transparent and readily communicated and available to the public. Next slide. Next slide. Our challenge is that we have 43 not-for-profit hospitals, and in some of our most recent reporting identified that approximately close to $23 million were in terms of resources allocated to community benefit were reported to the IRS in terms of satisfying the requirements. The challenge, though, is that there's not been a process at the state level of navigating accountability in this space. Of note, there are approximately 29 states and including or in addition the District of Columbia that actually have legislative mandates to where those states provide some level of oversight and or direct state accountability for community benefit and community health needs assessment reporting. Unfortunately, in Louisiana, there are no requirements in law that ensures that the community health needs assessment reports and or processes are tied to the community benefit dollar allocations. Additionally, there are no requirements that identify that and or laws that that require at a state level that these are made public to the that the results are made public to the available to the public. Lastly, there are no requirements or legislation that requires that there has to be an evaluation of how community benefit dollars are impacting health outcomes across the state. Next slide. So accordingly, our main charges are really, or objectives are really to address accountability and to navigate a process in which we can begin to show improvements and outcomes for underserved communities through a transparent engagement of both the health needs assessment and community benefits processes. Next slide. So our core initial recommendation in this area is that not-for-profit hospitals should be required to provide their documentation of their community health needs assessment to the health standards section of LDH. This does not require any additional work or development of any additional tools. It simply requires that the same documentation that is forwarded to the IRS will now be captured at the level of the state through the health standards section. Next slide. Our second recommendation focuses on an accountability process in which there's the establishment of regional committees, which will evaluate and analyze the evaluations of the needs assessment and the programming that's developed around the community benefit dollar allocations. The representation of such committees would include both the regional and elements of both regional and central leadership from LDH, would critically involve representation and leadership from the Office of Health Equity and Community Partnerships, where appropriate, input from academic medical centers from a regional context, the Louisiana Public Health Institute, or LPHI, but most importantly that we would have included in this process organizational stakeholders who are directly reflective of the communities in the regions that are influenced by the health centers. Next slide. Our third recommendation is a fairly heavy lift, but an important lift, and that is that hospitals should really allocate at a minimum about 30% of funding to programming around community benefit. And the community benefit programming, again, should directly be linked to the needs assessment process. This is a major upscale from what we've seen documented in the literature from many similar centers across the country, but it then represents a significant investment in how we have a direct, actionable accountability to this important space by our health centers. Next slide. In the conduct of the health needs assessment, we want to make sure through the lens of equity that there's sufficient education that's required for those who are participating in the process, so that when we go through the essential methodology, the objectives that are important from a health department standpoint, and just the processes of collecting data and the essential partnerships that allow for a very comprehensive needs assessment, that again, through the lens of equity, there should be formative training that where there's oversight at the state level for ensuring that these processes work the way they should. Next slide. Our fifth recommendation focuses on really the simple process of once this background framework and infrastructure is established and is operational, that we join the other 30 states that have some level of accountability that's in law to move our first recommendation into Louisiana law within 3 years of its inception. Again, this creates accountability to in terms of the responsibilities of our hospitals, our medical centers, and then once it's in law, it then establishes a given level of accountability to the oversight of the regional committees that we've described, and it allows those committees to have opportunities to leverage their input and oversight in the process. Next slide. And then lastly, we very much support that that these activities should add to the responsibilities and work of Dr. Benjamin's office in health equity and community partnerships as a key driver for oversight of the effectiveness of this framework. Recognizing that, though, we do recommend that that sufficient resources are added to that office to allow for that work to be done in an effective and transparent fashion. Next slide. So our last area focuses on the space of healthcare workforce development along a continuum that will serve to decrease medical mistrust and the influence of bias in the delivery of care. And as noted on this slide, this really is a continuum that begins with, how do we navigate the pipelines or the streams or the flow of individuals into the healthcare health professions dynamic? How do we navigate the training space, and how do we ultimately engage the community? Next slide. Now, as background, it's obviously evident to all of us here that many of our communities, specifically our communities of color, are negatively impacted by the influence of bias that's really exerted or exhibited by both systems and providers, and this results in differential standards of care that we've borne witness to over the years of the work that we've done. And importantly, we're just now having these critical conversations that underlying structural racism is what often is the underlying component of what drives this, and that we have to recognize this and identify how to best navigate structural racism that contributes to bias and mistrust, because ultimately the existence of bias and mistrust translates into patients in our communities disengaging from care, and also ultimately experiencing a greater burden of adverse health outcomes. Next slide. So our objectives, we have about 3 or 4 core objectives in this space, and the first is in the purpose of how we build our healthcare workforce. It begins with pipeline, and we recommend that there's an investment at the level of the state in establishing resources that support the development of pipeline initiatives that serve for outreach at the secondary school levels, that serve to expose and foster greater participation from students from underrepresented communities. These pipelines then need to extend and move into our undergraduate and collegiate spaces, in which we have structured programming, especially within our state colleges and universities, structured programming that fosters an increased matriculation of students from underrepresented communities into health professions training. And that underlying this should be an expansion of mentoring resources that are critical. Next slide. When we look specifically at our health professions training enterprise, our core driver is to look at how do we diversify the representation of underrepresented communities in the health professions community. This is a key driver that's been identified nationally as one of the core components of affecting health disparities and health equity. And so this means that we have to increase the matriculation of students from underrepresented communities into medical school, dental school, nursing school, and allied health programs. And that this has to happen within Louisiana that's reflecting our state demographics. This has been our challenge. If we just simply look at our experience with medicine, only 7% of the physicians in the state of Louisiana who are licensed and practicing are African American. But when we look at our health professions programming, only between 5 to 7% of our medical school classes, and this includes Tulane, LSU Shreveport, and LSU New Orleans collectively, only between 5 and 7% of our classes are African American in terms of either total enrollment or graduation. And this is the most recent data. And so if this is what we're seeing in our training programs, then it's going to be impossible for us to move the needle and change the composition of our actual practicing workforce unless we really meaningfully move this in a different direction. And so the data that navigates this space needs to be transparent so that we understand who's applying, who's matriculating, and who's graduating throughout the range of our different health professions programs. We, on a different front, need to assess, we need to empower the capacity of those who are in training, and that is in focusing on developing important curricular tools that address the training of our next generation of providers in the space of health equity, cross-cultural education, structural competence and cultural safety, and reductions of implicit bias. Very interestingly, there was a recent legislative occurrence in which House resolution and in the House a resolution was passed, Resolution 33, with unanimous bipartisan support to make direct recommendations that this type of there should be accountability for the development and monitoring of this type of education within our health professions programs across the state and as navigated by even our licensing entities for health providers in the state. And that this work should be partnered again with the Office of Community Partnerships and Health Equity. Next slide. With regards to how we navigate some critical areas within the actual delivery of care, we need to look at how we can best reduce bias and racism and the experience of exposure to racism experienced by patients in diverse healthcare settings. A first step is to actually perform critical assessments using satisfaction surveys and tools to evaluate patient quality and patient experience. We need to incorporate questions that directly assess bias and exposure to racism. And that needs to be reported transparently and in a way that can be used in an actionable fashion. We importantly need to create monitoring to evaluate referral patterns amongst our care networks throughout the state to identify when we see evidence of de facto segregation in different health systems based on either race or income or insurance status. We know that we've actually seen this. This is not something that was just in the before times, but we've seen this even in the present. And so this needs to be monitored so that we can create action to prevent this or to reduce this. And then we need to look at how can we mandate or navigate funding that provides for patients who are either using Medicaid resources who are otherwise underinsured, that they're able to share equitably, that these resources are shared equitably amongst private-public partnerships that foster and enhance increased access to care amongst all systems. There has been some recent legislation that's addressed, in essence, Medicaid dollars following the patient. So if these things have begun to move, then we need to create structures to monitor how these things occur. So again, we see what the impact is on equity. And next slide. And lastly, in this core objective, we want to look at how do we engage directly with the community so that we increase direct collaboration of our health systems with community stakeholders to advance equity. And so an important starting point is to foster a transparent commitments by our health systems in partnership with communities to identify key priorities. A key driver and priorities of the systems is to advance equity in terms of their business models and how their business models interface with the community. Accordingly, consistently with the recent House resolution, the type of training in terms of cultural competency and bias reduction is not just a function of training and education that takes place in the space of our health professions educational programs, but also these things need to occur within our health systems for administrators, for clinical providers, for staff, for those who are licensed to provide care. And again, this was addressed and set forth in the resolution. And so we need to look at mechanisms again with the Office of Minority Health and Community Partnerships. We need to look at how we can provide some oversight for this. And then lastly, we need to have mechanisms and tools for research at a community level that can characterize and identify what the patterns of bias and disparities are that are experienced by our communities, and that research will also be important to characterize the effectiveness of the interventions that are developed and employed. We have to understand both what exists and what we're doing if we are going to be able to continue to grow and develop our resources. And last slide. And so we close with our committees acknowledging or identifying that health care is an essential human right, and so the recommendations that we're putting forward are in that context. And so we hope that many, if not all, of these recommendations will be critically considered because they do translate into our uplifting and upholding healthcare within Louisiana as a human right, and moving us from, ranking 49th in almost every measure, whether we're looking at the pandemic or whether we're looking at our ongoing health indicators, 49th or 50th in the country. It's time for us to make these changes across our system so that we can achieve better. So I thank you, and our committee is happy to take questions.
Thank you, Dr. Mopan. You were absolutely right. Your committee did have a heavy lift, and you all delivered. This was an outstanding, comprehensive report. We'll entertain any questions at this time. Any of your committee members have anything to add, Dr. Mopan?
Would welcome any additional input from our committee members if they would like.
I would just say that, Dr. Maupin, thank you for representing our committee's work the way that you did. It was a heavy lift. A lot of hard work went into it, but we think that we came up with short and long-term actionable solutions. And so we're looking forward to how it is received by the governor's office, and hopeful to be able to move forward on some of the key items addressed. We worked, Dr. Christy Anderson and I worked specifically on the aspect of community health needs assessment and community benefit. And we find that that is an area where it's not new dollars, and just providing some accountability and framework that we will be able to direct those dollars to actual programming that benefits our community and can be evaluated. So thank you again.
And I'm really proud to, this has been an extraordinary group of folks, and we've really focused on things that are actionable and doable. So there's no excuse not to get everything we recommend done and then move on to other things. This is really important work, and it's a fantastic committee. And Dr. Maupin, you did a fabulous job. Thanks for presenting.
Thank you. Okay, we will move forward to public comments. We have had several public comments come in. They're not germane to items on this particular agenda. However, I would like to just share with the task force. We've received more than 50 public comments supporting the recommendations of the prison subcommittee. Please know that due to the number of comments and the limited time that we have, we're unable to read every comment publicly. However, these comments will be forwarded to the prison subcommittee. And the overarching theme of the comments was that they supported the recommendations of the prison subcommittee. So we do thank the citizens and organizations who are supporting this work. At this time, I would like Secretary Kimberly Robinson, if she has any closing remarks that she would like to add. You will be receiving these 3 committee reports that we will be laying at the governor's feet. And I think that you have a statement that you wish to share with the committee.
Well, thank you, Dr. Brown, and thank you to all the committees for your work. The 3 new reports, as well as the previous 6. I appreciate you all making them so very lengthy and thorough as the reader of them and the summarizer of them. He does get all of them, but he likes to get the executive summary version. So when he gets asked questions about them, he can answer those questions if he hasn't finished reading them. So I can tell you that he's supportive of your work and the expertise of all the members, and he's reviewing the recommendations, and we'll have a plan for which ones we can implement and take action on. And as he's continued to say, the pandemic has highlighted what many people have long known, that racial disparity exists across our state and affects the health outcomes of all of our citizens. That's the reason he created this task force. We have seen our numbers spike again, and we know the importance of the work that you're doing. So we will continue to move forward. We ask that you continue your work. And thank you to our co-leaders and the partnership between Southern and Tulane. Even the links on your websites now, as Dr. Rivera has pointed out. And I don't know that the 2 of them shared with the committee, but they will be doing a press conference on Monday announcing a study that will commence on the 15th. So I will let them talk about that. I won't share that. They will be able to share that with you. So Dr. Brown, I will turn it back over to you.
Okay. And the study that Secretary Robinson was referring to is the Ochsner prevalence study that is being funded through the Health Equity Committee. And so we will be learning more about that study, but they're going to be doing a massive prevalence study, and we'll be learning more about it on Monday. Terry Sterling, are you still on the line? Can you just give us a brief update on the work that you all are doing with the Resilient Louisiana Commission as of this date?
Yes, thank you, Dr. Brown, and also to Dr. Levis. Just have to pause for a moment and applaud the great work of this committee. The task force recommendations today were outstanding. There's great synergy around framing the question of equity. The Resilient Louisiana Commission issued its own statement regarding equity as related to how we were going to do our work. And really equity framing as a new growth model to not only drive how do families, individuals, as well as businesses recover from the pandemic. So at this point, our 15 task forces have completed their reports. It's about 500 plus pages. And so we will work through those documents over the rest of this month to develop our priorities and then move forward, much like this group has, to what are implementation. So we certainly continue to track together. Certainly after digesting the reports today, there's lots of similarities and lots of great work that we believe can collectively make an impact in our community. So thank you very much. And again, congratulations on wonderful work.
Thank you. As an order of business, Dr. Levis, should we call for approval of these reports, or?
Yeah, I think we should formally do that as we've done with the others.
Okay, so we'll call for a motion for approval to accept the 3 reports that were presented today. Do we have a motion?
So moved, Leanne Fowler.
Do we have a second?
Second, Takesha Davis.
Okay, so it's been moved and properly second that the 3 remaining subcommittee reports have been accepted and will be forwarded to the governor's office. So we've come to our last item on the agenda, which is next steps. And in the words of the Communication and Messaging Committee, it ain't over. So translation, our work ain't over. So where do we go from here? We're thinking that it'll be 2-pronged. One, as the governor has a chance to digest and review our recommendations through Secretary Robinson, we anticipate that we will probably be getting some more charges or to expand what we've done. We do know that regarding the Data and Analysis Committee, Secretary Robinson shared that there is new data that is now available for the committee. Remember, they reported that there were some missing data elements, and now LDH does have some of that data available. So there may be a part 2 to their report forthcoming, and we will streamline that accordingly. Regarding the prison subcommittee, the governor's office has asked us to look at some additional guidelines that they may consider incorporating. So they too may be convening to look at those guidelines and maybe doing a part 2 or an addendum to their report. The other ideas that Dr. Levis and I talked about, and I'll let him share more, we thought that it might be beneficial, since you all have been working so closely together, to give us some ideas of what you think might be some best next steps based on the work that you all have done in moving forward. Dr. Levis could weigh in on this from our discussion.
Yeah, I think you've done a good job of describing it. What we talked about was for each subcommittee to think about what is the next step. What other priorities within the sphere of your subcommittee, other things that we should be considering. And also, we'd like you to give some consideration to whether there are topics that we have not covered well. So for example, there's the economic impact of the pandemic. I do know that we really haven't addressed that very well. And so are there other topic areas that we need to consider, and with an eye towards possibly even reshuffling subcommittees and adding additional committees to address those topics, to make sure that we're putting together a comprehensive set of reports. So at next week's meeting, we'll likely have a visitor. I'm working on a couple of visitors from other state task forces from other states, so that we can just kind of hear what's happening in some other parts of the country. But also, we'd like each of the committees to just talk a little bit about other things that we can be doing as a task force, either within your own subcommittee, but also other areas that we're not adequately covering.
Right. And what we'll do to streamline that is probably maybe put together a little template with some structure on how you can think through this. But I know I speak for myself and Dr. Levis, as we looked at your reports and read the reports, we could not be more pleased. We could not be more grateful for the meaningful work that you have done, for the quality of the reports that you have prepared. And so collectively, we say thank you. Thank you for your work. Are there any other closing remarks or any other comments from anyone in the committee? Okay. Hearing none, we'll call for an adjournment, and pending whether we're able to get those 2 national speakers that Dr. Levis is trying to get for next Friday meeting, we will let you know for sure during the week about our meeting agenda for next Friday if we can secure that. All right. Thank you all, and have a wonderful rest of the weekend. And thank you for participating in today's meeting.
Goodbye.
Thank you.
Bye-bye.
Bye.